Okay, good morning. Today we will discuss about examination of a case of breast lump. The importance of breast lump is, a lady comes to you with breast lumps. They are always worried whether it's a malignant lump or not. So we have to follow the steps of history taking examination, and okay, of course after that we can go with the investigation. But at the stage of investigation itself, in examination itself, we should be able to distinguish whether it's a benign lump or a malignant lump. So that's the importance of breast lump. Today I will be concentrating mainly on a lump on the breast, not on other conditions, because that will be too elaborate to say. Mainly I will be concentrating on lump breast evaluation. The history, start with history as in any other case. Usually the age is a very important factor. Young age groups, you get more benign conditions, like very young, 20s and 30s, you get fibroadenoma-like conditions. Little more aged, 40s, 35, 45 age group, you get fibroadenosis, which again is benign. Little older group, you get carcinoma malignancy. But this was the old feature. Now, we see a lot of cases of carcinoma breast occurring in young age group as well. So just because of age, you cannot categorize the pathology of a lump in the breast. That's one point. First point I want to mention. Then, coming to the lump, most often the patient will tell you, I have a lump in the breast, right or left breast, which it is. So you need to take certain history. How did it start? How did you notice this lump? That's a very important thing. Some people will tell you that because there was a lot of pain, I noticed that. Or it started with pain, then I noticed there was a lump. This type of history is more indicative of either an inflammatory swelling like a mastitis or something like abscess, or even some people tell you this pain is coming in every cycle of menstruation, premenstrual cycle period. So that again is indicative of benign cyclical mastalgia, we call it. These are okay. Pain is a good sign, I would say, in a breast lump. Certain people will tell you, I just noticed while I was taking bath. Just when I was applying soap, I just saw some lump was there and noticed it's totally painless. It is there for some time, 2-3 weeks. That is something which will raise an alarm, because most of the malignant lumps in the breast start painless, and later stages only they get pain. So a painless lump you should be more worried about. Okay. Also ask about any pain in the breast. Is there any pain? And lump is there painless. Ask about is there any pain elsewhere in the body, like in the vertebral column. It may be suggestive of a metastasis. So pain, absence of pain is more worrisome than presence of pain as far as the malignancy point is concerned. Then ask what are the other symptoms associated with the lump. Is there any discharge from the nipple? Usually there are multiple types of discharge that are described, like a first discharge in abscess and ectasia conditions. There may be greenish discharge in a fibrocystic disease. Bloody discharge or frank blood discharge, you can see in few conditions like a duct papilloma or a carcinoma arising from the duct. So we ask whether there is any discharge from the nipple, and if there is any discharge, you ask about the quality of the nipple discharge. Also ask about is there any change in the nipple which has taken place, like a retraction, ulceration, or fungation of the nipple. Okay, some people will have it from developmental, from beginning. This will be like that. So you ask that if there is any change in the nipple, patient is talking about how long it has been there. Maybe congenital, it will be there from beginning, or recent change is more important. A recent change in the structure of the nipple is more important than the chronic stage. Ask about any loss of weight, loss of appetite, as in any malignancy case. Patient can get loss of weight and all this. Okay. So by this time you will be able to tell whether it's a benign and it's more of a malignancy. If you feel it's going towards malignant angle, like a patient is middle-aged lady, painless lump, last 3-4 weeks, 4-5 or 1 month, gradually increasing size. So these features will tell you possibly we are dealing with a malignancy, no, but not sure. Okay. So next group of questions you should ask, if you feel it could be a malignancy, is the metastatic history. You ask about whether there is any symptom suggestive of spread of this disease. Where it can spread? It can spread to the axilla. Ask about any swelling developed in the axilla or in the neck, suggestive of neck nodes, supraclavicular node enlargement. You ask whether there is any distant metastatic spread like lung, a cough, hemoptysis, breathing difficulty. Abdomen, you can have abdominal distension due to the ascites or liver enlargement, or an ovarian enlargement. or pain in the long bones, the vertebral column and long bones, suggests to metastasis, or any CNS symptoms. All this will give you an idea, made to roughly you can tell you whether there is any distant metastasis of the disease. Next group of symptoms you should ask in the history is the risk factors for malignancy. Suppose you are thinking in line of a malignancy. What are the risk factors in the history? What are the most important two risk factors? One is the female sex, because more than 99% of the malignancy carcinoma breast occur in ladies. Second is age. The statistics say in age, if you take a group of ladies aged 80, 20% of them are likely to get carcinoma breast. So these are the two most important risk factors: the female sex and the age. And there are so many other risk factors described in the various studies, like the marital status, whether the patient has the nulliparous or not, or lactation history, and early menopause, early menarche, late menopause, close family history, that is involvement of a family member, of the first degree family member, or it's also so many other conditions. There are obesity. Obesity is also, what are the relation with this, all these conditions produce hyperestrogenic state in the body. Obesity, early menarche, late menopause. So what is the concept about pregnancy and lactation? How pregnancy and lactation is protected? These are two contrary views. Pregnancy is not a protection. Pregnancy has got a lot of hormonal activity, so during pregnancy, malignancies will flare up. But following pregnancy, there is a period called lactation. Lactation, amenorrhea will be there, so hormones will be suppressed. So this suppression effect on hormone is protected. So combined pregnancy and lactation, provided the lactation should be for a minimum period of 2 years. That's why we say lactation is protective if it's for a minimum period of 2 years. Because the prolonged lactation amenorrhea is protected. So combined pregnancy and lactation, you can say it's a protective feature. Okay. Now, other past history. Now these are the history of risk factors. And all these are producing hyperestrogenism in the body, and hormonal manipulation will happen, and this will aggravate the already existing malignancy. Other factors, past history, about any other history of excision of similar lump in the same breast. The patient may have forgotten, maybe a lump was there, it was excised, maybe biopsy was not taken, maybe he has forgotten, she has forgotten, you should ask about that. Okay. Then, any history of lump on the opposite breast. Maybe there was a history of excision of lump on the opposite breast. Carcinoma breast, again, it's again a risk factor, isn't it? Lump on one breast, carcinoma on one breast. This patient can have carcinoma on the opposite side. So that's again a risk factor. So these factors should be asked about in the history part. Various history with regards to the risk factors should be asked. Also, past history should include other medical and surgical comorbid conditions, as in any other case. Now, after taking all this history, you will go into the examination. So by this time, you have taken the history regarding the lung, history regarding possible metastatic areas, history regarding the risk factors. You may have a fair idea what you are dealing with. But then you go into the examination. General examination should be done as in any other case. You look for a built-in nourishment. The patient is in pain of the lung, about the lung breast, or any other pain in the bone or anywhere. And also look for any pallor, any abdomen distension, all those things because of the metastatic spread. Or patient is dyspneic, all this will be examined in general examination. Now coming to local examination. We are examining the breast. If a male doctor examining, student examining, always a female attendant or your fellow friend should be there with you. Patient should be in an isolated area with privacy. Both breasts should be exposed. Don't expose with a small area and examine them. Both breasts should be properly exposed. Clothes should be completely removed, giving confidence and privacy to the patient. Okay. Then we start examining. Explain, but of course you need to explain what you are going to do. Patient will be apprehensive, and also a lot of, because breast we are examining, patient will be not operating also. So you should explain and then proceed. Okay, you examine the inspection. Inspection should be done in, all examinations should be done in 5 positions. That is sitting, with arms by the side, arms raised above the head, arms on the hip, pressing against the hip, then supine and as well as the semi-recumbent position and leaning forward position. These are 5 or 6 positions in which you examine any breast lump. Okay. So you examine well, each position has its own values. Supine and semi-recumbent position, you will be able to palpate the lump better. Okay, this is the position where you examine the lump better. If you raise the arm, you will be able to examine the puckering or the dimpling of the lump. Also the undersurface of the breast you will be able to. By pressing on the hip, you will be able to contract the pectoral muscle and you will be able to see the fixity of the lump to the pectoral muscles. So each position, and also leaning forward, you will be able to see whether it's fixed to pectoral muscles or chest wall. If it's fixed, it will not fall forward as the opposite breast. So each position has its own value. Now, inspect like in any other breast. You see this is size, shape of the breast. Is there any change in the size and shape of the breast between these two? The position of the breast will be pulled this side or that side. Any change in the position because of malignancy. We mentioned puckering and dimpling. What is puckering and dimpling? It's due to the infiltration of the Cooper's ligament. So 1 or 2 Cooper's ligament will be infiltrated, so that will pull the part of the skin. Little bit of dimpling or depression will be there. Okay. But this is not, don't mistake it for a skin fixity. That we will come to later. Okay, so see whether there is any dimpling. See the skin over the breast and the lump. Is it normal color, any dilated veins, any edema, which is called pudiorange. What is pudiorange? It is due to the infiltration of the dermal lymphatics by the malignant cells, producing blockage and edema. And you will see the attachment of the sweat glands and the sebaceous glands as wide dimples. So it will appear more like an orange peel. If you have seen an orange peel, it will be exactly like that. Edematous and areas of the pulled, widened areas of opening of the sweat glands can be seen wide open, just like an orange peel appearance. Also see whether there are any nodules, ulcerations in the skin. So nodules, ulceration, pudiorange, these are signs of skin fixity. Okay, nodules, ulceration, pudiorange, and inability to pinch the skin. So these are all features of skin fixity. So this can be inspected as well. Suppose there is an ulceration. It's not necessarily always it's due to a malignant ulcer. Suppose a large ulcer large lump like a giant fibroadenoma can just produce necrosis of skin, can ulcerate. So what they say, if it is due to malignant ulcer, there will be fixity and infiltration of the skin around the ulcer also. So you can just pass a probe. With a benign ulcer, you will be able to pass a probe around between the swelling and ulcer. But if it is a malignant ulcer, there will be infiltration. You will not be able to pass a probe. Okay. Next is you see the nipple. Position of the nipple may be retracted or it can be pulled up because of the lump on one area. It can be pulled up or can be changed, pushed to one side because of the infiltration of the lactiferous ducts. It can be retracted as we mentioned before. Can be retracted. Skin may be the nipple can be retracted, may be ulcerated and eczematous. Can happen. Ulceration can happen in carcinoma, eczema and excoriation can happen in a condition of Paget's disease of the breast. So you see about the condition of the nipple. Also see whether there are any nipples on inspection. There are any nipple discharge which we already discussed in the history part. Also see the areola. Is it normal, ulcerated, or is there any color change or distension of the areola because of the underlying mass? Now after inspecting this, go to the arm and thorax. If this is a lump, you know that the metastasis of the lymph nodes goes to axilla. There will be a lot of nodes in the axilla. This can produce lymphatic obstruction. This can produce an edema of the arm. So look at the arm of that particular site. Any edema of the arm is very important. Also see the thorax, chest wall. Inspect the chest wall because if it's an ulcer, a lesion which is infiltrating the chest wall, it can get large nodules in the chest wall also. So see whether there is anything in the chest wall, any arm edema, all these things you should be looking at. Also then after that you inspect the axilla and supraclavicular area in the neck. Any visible swelling suggestive of any lymph node enlargement. Then you do a test called raising the arm. So far you may be patient will be sitting arms by the side. Ask the patient to raise the arm. What are the purpose of raising the arm? On raising, the lump may become more prominent. Whatever lump you are inspecting will become more prominent sometimes. And what I told you, because of the puckering or the dimpling due to the Cooper's ligament, that area may pull this lump downwards, you can see the puckering and dimpling more clearly on raising the arm. The third purpose is that you will be able to see the undersurface of the breast. So far you will be seeing only this. On raising the undersurface of the breast will come into you. Any lump or any pathology you are missing, you can better see on raising. Still, if you are not able to see, you can raise the breast and see the undersurface, inspect if there is any pathology there. So, raise the arm and see. So that will finish the inspection of the breast. Okay. Always you should compare with, whenever you find an abnormality, compare with the opposite side. The opposite side will act as a control. The opposite side is supposed to be a normal side. So compare with, if there is any abnormalities, compare with the opposite side. Skin abnormality, compare with the opposite side. Okay. So opposite side will act as a control. Palpation. Now coming to the palpation. Patient can be, a breast lump is better palpated in a semi-recumbent or supine position. Lump, especially for a lump, the lump will be more evident in these two positions. How will you put the patient in the bed? Patient should be put in the bed. You can ask the patient to keep the arm raised under the head like this. And also you can put a small piece of cloth under the scapula on the same side so that the breast will not fall down. So it will be easy to palpate any lump in this position. Okay. As I told you, both breasts are exposed. You start palpating the normal breast first, because then you know what is the normal finding. Some people will have a nodular breast, both sides. So don't confuse it with the abnormal. How you palpate the breast? For convenience, breast is divided into 4 quadrants, centered around the nipple. Each quadrant should be palpated. This breast should be palpated with the flat of your fingers. Flat of your fingers, not the flat of the hand like this. Flat of your finger. Each quadrant should be gently palpated. There are 2 methods described. One is they're like a bowl-like palpation, like you can palpate it, or you can radial type palpation from here to there. You palpate. Each quadrant should be separately palpated with the flat of your hand. Why flat of the hand? The most sensitive part of your finger is the tip of the finger. Why you don't use the tip of the finger? This is the less sensitive part. So if you use the flat of the hand, the most obvious swelling will be only palpated. That's the idea. Okay. Lump due to carcinoma will be a very obvious lump. So we palpate with the flat of the hand, you will not miss a malignant lump, but you may miss other things. If you palpate with the tip, you can practice and see, you will feel lot of lumps, isn't it? All small lumps will be evident. Small nodular breast, small fibroadenotic cheek, everything will be palpated. But if you palpate with the flat, you will not feel all those lumps, but only very obvious lumps will be palpated, like that of a carcinoma or malignant lump. So all quadrants should be palpated. This is the axillary tail. Don't forget, this is also part of the breast. Palpate the axillary tail. Okay, axillary tail should never be forgotten. And also behind the nipple areola complex. This is the nipple areola complex. Maybe a lump is situated. You forgot. Then all quadrants, but you didn't palpate the central part. You may miss a lump. Palpate this area. Palpate the axillary tail area. So and also while palpating, you can squeeze this area and see whether there is any discharge coming from the nipple also. Suppose you detect a lump, it is a description the same like we have our second class, that of a swelling. That's the importance of taking the very basics first, isn't it? You describe it in shape of T. Always you see any local rise of temperature and tenderness, situation, number, size, shape, the margin. Margin will be ill-defined in a malignant. Maybe so this is one situation. A margin may be ill-defined in a benign condition like fibrocystic disease. Many often a malignant breast lump will be well-defined. Margin will be well defined. It's not that it will merge with the surrounding. It will be well defined lump. So, and consistency. Benign lumps like fibroadenoma will be having a well encapsulated short T feeling, like a well encapsulated feeling. Whereas in a malignant lump will be hard and nodular in nature. Okay, so consistency it will be a very important factor as well. Very important next finding is the plane. Suppose there is a lump here. Upper outer quadrant is the most common site where you get a malignant lump. Suppose there is a lump here. What is the plane of the swelling? What do you mean by plane of the swelling? Swelling is there in the breast, no doubt. Is it fixed to the skin? How do you know it's fixed to the skin? I told you the fixity signs like nodules, ulceration, pure orange, or fixed to the skin. So what you do, you try to separate the skin. You cannot separate the skin from the lump. You may be inclined to say maybe fixed to the skin. But how will you differentiate it from puckering? Puckering is that infiltration 1 or 2 of the Cooper's ligament. There may be some dimpling at some places. So what you should do, you try to mobilize the lump. In skin fixity, you won't be able to separately move the lump at all. If it moves the lump, the skin also moves along with this. But in case of puckering, there will be some independent mobility of the lump. At some stage, the infiltrated Cooper's ligament will become tight. From that point, there will be no independent mobility. You can the dimpling becomes more obvious. I hope it's clear, isn't it? Skin fixity means no independent mobility at all. Puckering, there will be some degree of independent mobility. At the area it reaches the extreme where the infiltrated Cooper's ligament becomes tight, you may feel the dimpling and the independent mobility stops there. Okay. This way you can differentiate between the skin fixity and the dimpling. Next, how will you say whether it's fixed to the breast tissue? In a freely mobile lump like that of a fibroadenoma, you can mobilize the lump from here to here, here to here like that. Freely mobile, because it is fibroadenoma is encapsulated. There is no adhesion or infiltration to the surrounding breast tissue. So free. Whereas in malignant lump, it is not like that. Usually there will be no capsule and there will be some infiltration or adhesion to the neighboring breast tissue. So how will you do? You fix the breast tissue, try to move the lump. So you'll find, mostly you'll find the swelling moves, but the breast also moves along with that. It will not be moving independent of the breast tissue. So this is called fixed to the breast tissue. So that's the second plane. Third plane you check is whether it is fixed to the muscle, the pectoral muscles. Or pectoral muscle and fascia. How will you do that? First you keep the patient by the arm by the side, try to move the swelling. So the pectoral's major muscle fibers are in this direction, isn't it? So you move the lump in the direction of the fibers and against the mobility. Right? Opposite direction also. Then ask the patient to contract the pectoral muscles, like keep the arms on the hip and contract. Press against the hip. How will you confirm whether the muscle is contracted? You can palpate the anterior axillary fold, which will be taut. Okay. Then you try to do the same thing in the direction of the fibers. Mobilize the lump in the direction of the fibers and against opposite direction. If it is fixed, first the opposite in the line of the fibers, this mobility will be restricted more. Sometimes very good big fixity, both directions will be fixed. But mostly more will be in the direction of the fibers. So that indicates it is fixed to the pectoral muscles and fascia. The fourth phase level of the infiltration or the plane is the chest wall. What constitutes the chest wall? The ribs, intercostal muscles and the serratus anterior muscle. So what you do? What happens if it is fixed to the chest wall? The lump will be immobile even in the relaxed position with the arms by the side. You try to move the lump, it will not move at all because chest wall is a fixed structure, it will not move. How you determine whether the lump is fixed to the serratus anterior? Mostly the lump with the outer inner quadrant of the lump. A lump here will be fixed. There is a more likelihood of getting fixed to the serratus anterior. How will you fix the serratus anterior? Patient should be pressing against the wall, and then in that position you will be contracting the serratus anterior, and then same thing, you try to mobilize the lump, it will be fixed. Okay, so these four planes should be determined: skin, breast tissue, the pectoral muscles and fascia, the chest wall, which includes the serratus anterior also. So by this time you know which plane the swelling is arising from. So we already described about the chithering or the puckering, which is due to the infiltration of the Cooper's ligament. Fixity of the skin due to the direct infiltration, which is indicated by immobility or not able to pinch the skin, nodules, ulcers, and fluid. If all these are there, you will be able to say whether it is fixed to the. Okay. So all this after describing all these features, you will be able to tell us about the nature of the lump, the size and shape of the lump, which quadrant it is situated, okay, which plane it is situated. Okay, so by this stage you know what is the stage of the disease also, because if you know at least the T stage and end stage, end stage you have not done anything else. Now, what do you do next? If there is an ulcer, suppose there is an ulcerated lesion, ulcer should be described separately, okay, as we described in the other case. Of an ulcer. Any ulcer, you should describe in the same way. Next is the important feature is the part of examination, the lymph nodes. You know, malignancy of the breast spreads to the lymph nodes, mostly to the axillary node. You have to palpate the axilla. Okay, suppose this is the right side axilla. For pathology is on the right side. Patient sits in a chair. Then you will stand in front of the patient. Suppose you are examining the right side of the patient. The right arm will be kept on here, and you will palpate with the left side. First, you palpate with your left arm. With the left arm, you can palpate the central, apical, and medial group of nodes. The left arm. Okay. Central, apical, and medial group of nodes are carefully palpated. Okay. The interpectoral nodes can be palpated between your thumb and index finger, like the interpectoral nodes, because you can palpate the pectoral muscles here, and interpectoral nodes group can be palpated between index and thumb. Other parts of the axilla, medial, central, and apical group of nodes are palpated with the left hand. The lateral group of nodes, that is lateral wall of the axilla, is the arm, isn't it? So we can palpate with the same hand, either with the right axilla is palpated with the right hand, like this, the lateral aspect. Then there is another group, scapular group of nodes, which is usually palpated standing behind the patient. Standing behind, the right axilla is palpated with the right hand. From behind, subscapular group of nodes are palpated in the posterior wall of under the posterior wall of the axilla, which is formed by the latissimus dorsi. Under the axilla, posterior fold we palpate for the subscapular group of nodes. So you should know now what are the groups of nodes and how you palpate. Most of the groups are palpated with the opposite arm. Lateral group and subscapular nodes can be palpated with the opposite, the same arm. Right side with the right arm. And subscapular nodes can be palpated standing behind the patient and palpated. Okay. So this group of nodes, whether the nodes are detected, you should identify the number, consistency, mobility, fixity, any matting. Number is very important. These days TNM stage, end stage is determined by the number. Okay, so you should try to determine how many, rough estimate of the T1, T2, T3, how many nodes are there. You should be able to say. Next is the cervical node. Again, better palpated from standing behind. The supraclavicular nodes are palpated. Before, sometime back, before maybe 1 or 2 TNM state classification before, involvement of supraclavicular node was considered as a metastatic. Now, the recent TNM staging, involvement of supraclavicular node is not more metastasis. This is advanced end stage only. So that is because the supraapical group of nodes we mentioned. Next group of the supraclavicular nodes. So it's due to the contagious spread. So it becomes only the next stage. It's not an metastatic node at all. But this type of lymph node description is only for anatomy. We describe the anatomy of the axillary node by level 1, level 2, level 3. Okay. In relation to the pectoralis minor tendon, that is below and lateral to the pectoralis minor, we call it level 1. Under the pectoralis minor, we call level 2. And above medial to the pectoralis minor, we call level 3. Okay. So that is for when you do surgery, we describe it like this. So level 3 or apical, or the other name for the group is the infraclavicular node. From infraclavicular node, it goes to the supraclavicular. So it's like a contiguous spread, not a metastatic spread. That is why supraclavicular nodes are not considered as a metastasis disease in carcinologists. Okay. So you completed the examination of the lymph node. Opposite breast also is to be palpated at this stage to see whether there is an in-lump or axillary node on the opposite side, or opposite supraclavicular node also. After completing, you should examine the other systems to see whether there is any metastatic spread, also any comorbidities. Which are the systems usually? You should auscultate examine the respiratory system for any absence of sounds, abnormal sounds, all these things. For palpate the skeletal system, it can spread to the thoracodorsal spine or long bones, any tenderness, swelling in the spine and tenderness. You should see. Abdomen you should palpate for any, can spread to the metastasis, can happen to the liver, can produce ascites, it can produce enlargement or deposits in the ovary. Okay. Should also do complement it by doing a PR and PV examination, because pelvic mass, the ovarian mass may be examined better with a pervaginal examination. Okay. So thereby, and also a brief CNS examination. If you have any symptoms, you can examine brief CNS examination also. Thereby you are covering all the metastatic sites by examining yourself. Okay? And after this, you should be able to describe the lung and possible pathology and possible clinical TNM stage, depending on the size and lymph nodes and possible metastasis. You should be able to tell us, is it possibly carcinoma of the breast, clinical TNM stage, whatever it is. Okay? So these are the basic steps in the examination of the carcinoma of the breast or any lump in the breast. You follow this and you can come up with a good clinical diagnosis. Okay? Thank you.